it gives me great pleasure to introduce our summit plenary speaker and keynote address from Dr. Daniel Dawes, who will be joining us shortly. Daniel Dawes, Esquire, is Executive Director of the Satcher Leadership Institute at Morehouse School of Medicine. He's also a Professor of Health Law, Policy, and Management. Daniel is a highly respected healthcare and public health leader, health policy expert, and educator and researcher. A trailblazer and nationally respected voice in the health equity movement, his scholarship and leadership, particularly the innovative political determinants of health framework that he pioneered, has resulted in increased policies and laws prioritizing health equity. By tackling upstream determinants of health, he has ventured into such uncharted territory as to the intersection between equity and the social and political determinants of health to change the course of domestic and global policies for the better. You can find a more detailed version of Daniel's bio on our website, but please join me in welcoming my friend and colleague, Daniel Dawes, Esquire.
Well, good morning, everyone. I want to thank Dr. Arno for that very warm introduction, and to all of you for the incredible work that you have been doing, the courageous and humbling work that you've been doing in the District of Columbia to move that needle of health equity forward. Thanks again to Dr. Hewitt, Dr. Nesbitt, and to Dr. Arno for the invitation to join you and to present this presentation. You know, as I think about this dark and historical moment that we're in, it reminded me of an experience that I had with my brother Patrick. Basically when I was about 16 years old, had just gotten my driver's license, and we decided that we wanted to go to a different church than my mom. And so we asked her if we could borrow her car. We went to church, but we were running late, right? The service had already started. So we get into the church as reverently as possible, and we take a seat in the back pew. And all of a sudden, my brother Patrick starts falling asleep, starts putting his head down. And I said, "Patrick, wake up. What are you doing? You're going to miss the service." And he says, "Leave me alone. I'm trying to sleep. I'm tired." I said, "Okay." About a couple minutes after that, he starts falling back asleep. And I said, "Patrick, wake up. You're missing the song service." He says, "Leave me alone. I'm trying to sleep. I'm tired." At this point, a few church members who were seated in front of us started turning around and giving us the stink eye and told us to keep quiet. And I said, "Okay, fine. I'm going to leave him alone." Well, a few minutes later, the pastor gets up, the preacher gets up to the podium, and he said, "Church, we've got to wake up. We've got to wake up, church." All of a sudden, you see Patrick stunned, looking at me like, "Oh my God, is he talking to me? What's going on here?" I tell the story not to embarrass my brother Patrick, but to remind us that sometimes we all need a wake-up call to understand the moment that we are in, right? To get us moving into action, because it really does matter. We are now in the fourth period of this great awakening for health equity in America. What are we going to do about it? How are we going to leverage the opportunity moving forward? Well, I obviously have a lot to cover today, so let's begin. In her inaugural poem, the past National Youth Poet Laureate, Amanda Gorman, reminds us, among countless soul-piercing refrains, that being American is more than the pride we inherit. It's the past we stepped into and how we repair it, right? So to move beyond merely nibbling around the edges of the problem of health inequities in the District of Columbia and effect more meaningful and effective solutions, we have to first look back, dig deeper than we've been willing to do to uncover these inequities, examine how they've been concretized in our structures and institutions over time, in our systems over time, and address the laws and the policies that propped them up. So today we are going to look at how we can repair the past and how we can leverage the political determinants of health to effect the changes that we so desperately need in our communities to advance health equity and health justice. So this is Lady Columbia, or Lady Justice, representing the great United States of America. And as you can see, she's holding the scales, the balance in her hand, with so many vulnerable people falling out. And as we've seen throughout the last 2 years, and even beyond that, too many vulnerable and marginalized groups have found themselves in a precarious situation. Their health, their lives, hanging in the balance, so to speak. Many of them have been falling through the cracks of our health system, education system, human services, behavioral health, housing, employment even, right? And beyond. Just let these statistics wash over you for a moment. Because as you can see, these under-resourced groups have struggled to live in a society that has intentionally erected barrier after barrier to weaken their bodies and hasten their deaths, leading to the striking inequities in health systems, healthcare, and life expectancy that we now see in the District of Columbia in the United States of America. So why is this happening? Well, this is happening despite the fact that America spends more on healthcare than any other country on earth and consumes more than half of the world's healthcare resources. You see, prior to the COVID-19 pandemic, the United States ranked number 43 in life expectancy in the world. Interestingly enough, when you disaggregated the data, it's really compelling, right? What they also found prior to COVID-19, right before COVID struck the United States, a major study was published by The Lancet showing that the United States was expected over the next 20 years, as we were increasingly becoming a more diverse society, a racially pluralistic society, the country was expected to drop 21 places in life expectancy to 64th in the world. And whereas the rest of the world was expected to gain 4.4 years onto their life expectancy, the United States was lucky to even gain 1 year. Imagine now with COVID striking us and with nearly 800,000 lives lost owing to COVID, a very conservative number, how much more our country has dropped in its life expectancy. Well, when you disaggregate this data even further, right, it presents quite an incredible narrative. If we took all white people in America and they became their own country, they would rank 50th in the world. Think about that. We rank 43rd in the world collectively, but if you disaggregated our racial and ethnic groups, whites would rank 50th, lower than 43. If we took all African Americans, all Black folks in this country, and they became their own country, they would rank 103rd in the world. And if we did the same for indigenous populations in this country, they would rank 143rd in the world. This is a sad and unjust display of how racism divides us as a country. The bottom line is that we all could be doing better, and we all should be doing better for the sake of our country's health. Well, we know that racial and ethnic minorities, people with disabilities, lower socioeconomic status individuals, LGBTQ plus individuals, and others die disproportionately each year. And the toll that it takes is unconscionable. But the one thing that I hope we will always remember is that our country's health is not an organic outcome. It is not a coincidence that certain groups of Americans experience higher premature death rates or poor health outcomes than others. Why? Why has this been happening, right? Well, today we recognize that there are a variety of forces collectively impacting our health and determining the quality and the extent of our lives on this earth. They include the social determinants of health, behavioral health, environmental, economic, healthcare, and genetic factors. Now, key among these determinants are the social determinants of health, the structural conditions in which we are born into, we live in, and we die in that affect all aspects of our health. And of course, these social determinants of health play an outsized role in these human-made pre-existing inequities. But underlying each one of these determinants, multiple interacting determinants of health, is a political determinant that we can no longer ignore. You see, too often we've been stopping at the social drivers of inequities, failing to look back and dig deeper, as I mentioned earlier, right? To see the depths of the problem and to understand its root causes and distribution. And as a result, we've been missing the link between the social determinants of health and their policy roots. Because you see, for every one of these social determinants of health, when you think about the structural conditions in which we live in, there was a preceding legislative, regulatory, legal, or other policy decision that resulted in the social conditions or the structural conditions that we find ourselves in. So let me illustrate this concept, this idea, with a short story. If you were to envision all of society, all of the District of Columbia, for instance, right, sitting on the banks of the Great Potomac River, fishing and finding nourishment in the resources that the river provides. The health inequities that we face are represented by the differences in the caliber and the quantity of fish we encounter. Some people have a bounty of healthy fish and vegetation to feed off of, while others may only have small fish, maybe no fish, no vegetation, or malnourished fish. Different people having access to different types of resources and different parts of the river represents the social determinants of health. Now, some people are located in a slower moving part of the river by no fault of their own. Others are located in more lush parts of the river and benefit because of such, by specific decisions that were made on their behalf. These are the political determinants of health. You see, somewhere upstream, decisions were made to divert the river, to benefit certain people, and to harm others. And decisions were made to place certain types of people on specific banks of the river while placing others elsewhere. These upstream decisions absolutely have downstream impacts. And this pandemic, this endemic that we've been going through, this quadruple pandemic, in fact, demonstrates the inconvenient and harsh truth about the impact of the social determinants of health and how collectively these factors significantly contribute to our society's inequities. It shows the compounding effect of political determinants over personal responsibility, because no matter how much many African Americans, Native Hawaiians, Latinx Americans, Pacific Islander Americans, and lower socioeconomic status individuals try to act responsibly, there are always structural, institutional, interpersonal, and yes, even intrapersonal obstacles that have been hindering them. Beneath these communities' notice are political determinants that have pulled and continue to pull strings that prevent them from achieving their optimal health and their full potential. And so is it any wonder then why COVID-19 has not been striking all groups equally? Well, no, when you think about it, because our economic and social policies have not been benefiting all people equally. Think about what's been going on during the last 2 years. We saw from CDC data, right? The declines in life expectancy for Black and Latinx individuals. Blacks lost 2.9 years of life. Hispanics have lost 3 years of life. And just this Monday, the CDC released their all-cause mortality data, showing that what we all knew prior to COVID, that communities of color experienced the highest amounts of health inequalities in this country. But interestingly enough, what we've seen over the last 2 years are that these Black and brown communities have seen an increase of from 30 to 40% deaths, again, owing to COVID, but all of these issues that they were dealing before the pandemic. And so when you think about political determinants of health, when you think about who gets tested, who's been able to get vaccinated, the quality of care, who gets access to healthcare, and the quality of care, right? Who can afford to safely shelter at home, the transportation that's needed to get to testing or healthcare, accessing the internet, even simple things that we may take for granted, like accessing water and accessing food, are all politically determined. So the health inequities that we've been talking about in communities across the nation, in effect, highlight how one political determinant after another resulted in a continual tightening of a chokehold on these communities and the eventual disaster that brought to light the inequities that have been plaguing them, notably high obesity rates, diabetes, maternal mortality, infant mortality, depression, and many other health issues can be firmly linked back to political action or inaction. You see, by understanding the political determinants of health, their origins, their impact, and their interconnection with the other social and environmental determinants of health, we will be better equipped to develop and implement the actionable solutions to close these health gaps. So for a moment, I want to paint this picture of the tree of health with you. Initially, you may notice on your screens a tree, even the fruit on the tree, the individuals or the tombstones surrounding the tree. But actually, this picture is far more representative of what our society currently has to offer some of its most vulnerable people. You see, the tree represents society. And yes, there have always been co-laborers in this fight for health equity. And I know many of you, in fact, have been co-laborers in this movement who have tended to this tree. We have worked tirelessly to feed the tree evidence-based policies, programs, and practices with the hope that the tree would provide fruit that would benefit all of society. However, the reality is that there have always been others who've been working overtime to supply the tree with that which would do it harm. These are the roots that are undergirded by racism, sexism, classism, and ableism, and many other deleterious motives. From the bottom of the tree's base, all the way up and through to the ends of its branches, what is supplied to the tree is then eventually multiplied by the tree. So now, due to the root causes of inequities, the fruit represents higher rates of diabetes, inaccessible, safe, and secure housing, a lack of nutritious food, and any other number of those outcomes that we attribute to the social determinants of health. And as that poisonous and sometimes rotted fruit falls to the ground, the tree that had the potential to provide life-giving nourishment to all who encountered it now only leaves death and destruction in its shadow from one generation to the next. But I hope you realize that all hope is not lost, right? Bob Marley reminds us that when the fruit is strong, the fruit is sweet. So now I want you to imagine with me what could and should have been. The roots of the tree, which anchors the tree and are supposed to absorb nutrients from the soil, represent the political determinants of health. And the detrimental factors that the tree's roots were and have been absorbing include racism, sexism, classism, ableism, homophobia, many other evils. Every political and policy decision that is made feeds into the tree, yielding fruit which permeates throughout our society. But if the tree of health is rooted in health equity, the end result is a society that is nourished, cared for, and capable of achieving its full potential. Because, again, when the root is strong, the fruit is sweet, right? So this begs the question, how did we get here? How did we get to these stark health inequities in our society? How is it that inequality gets under our skin, leading to accelerated aging or biological weathering, as Dr. Arlene Geronimus at the University of Michigan has coined? How is it that it increases the earlier onset of chronic diseases, as other researchers like David Williams at Harvard have identified, destroying the economic and social fabric of our neighborhoods? Well, today I want to take us back to look at big P policy and little p policy for a moment, governmental and non-governmental policy. And I'm not going to start at 1619, although I do believe that is a fair starting point. I'm going to start at 1641, and I'm going to start there for a reason. We know that the impact of slavery has been associated with long-term impacts on contemporary mortality, poverty, heart disease, maternal and infant mortality, and the list goes on. And so as we think about the social determinants of health, we need to think about how they came to be in the first place, right? Why is it that our communities look the way they do? So let's go back 400 years to 1641. This was the point in time when abolitionists were making headway in their fight, basically, for freedom, right? To abolish slavery and to advance a health equity agenda for our most vulnerable and marginalized groups. Well, as they were gaining success in their movement, the business interests, the commercial determinants of health, if you will, commercial interests, wanting to sustain their business model of slavery, recognized that they needed to codify that evil institution into law. And so they worked with the policymakers, first in Massachusetts, to develop a template, the body of liberty law, right? That was then used by policymakers in Connecticut, Maryland, New York, and others to legalize the institution of slavery. It was then amended over the years to include the offspring of Black enslaved people. And as if that were not enough, what we saw into the mid-1600s was an effort to then create business interests working with these policymakers to develop policies that intentionally and explicitly prohibited Black and Indigenous populations from being able to raise their own food. They were prohibited by law from earning their own money, from learning to read and write, from being educated, especially around English. They were prohibited by laws and policies from moving, right? From congregating in large numbers, from walking beyond a 1 mile radius, from walking at night without lanterns. They were prohibited from walking without permission slips. We know the list goes on, right? What we call these social drivers of inequities were instigated by these policymakers and these business interests back in the 1600s. What we then saw were these policies that were recycled from one generation to the next, from one century into the next, from the 1600s into the 1700s, into the 1800s, where Jim Crow reared its ugly head with a vengeance, right? And we saw the proliferation of racist, explicitly racist policies at all levels of government, local, state, and national. Today, we've seen the impact through public health research that these policies, these political determinants of health have had on the health of Black and Brown communities. Epigeneticists have shown the intergenerational trauma owing to slavery. We've been able to show the direct link to aggressive breast cancer prevalence in African American women, right, who deal with the isms of our society, racism, sexism, classism, you name it, and now today have the most deadly form of breast cancer, right? Well, interestingly enough, after this period, as we entered into the 1900s, we see how creative racists are in leveraging policies to advance their cause. And so as civil rights champions, lawyers, and public health champions and physicians and community activists got together and made the case to the Supreme Court that, creating policies that explicitly exclude one population group from another are unconstitutional, the Supreme Court could no longer ignore that argument. And so they said, you're right, it is a violation of the law. So what do? We then saw a movement from explicitly racist policies or explicitly discriminatory policies to what we term as facially neutral policies. So on their face, they didn't say African Americans or Latinos or Asians or anybody else could be excluded, but they crafted the policies in a way to intentionally exclude population groups. Social Security Act was key among them, right? But there were a host of other laws that I want to bring your attention to, right? The Homeowners Loan Corporation Act was one of those. As we came out of World War I, the country was in a crisis, an economic crisis. There were people who were malnourished in our country. The government was trying to figure out what to do. People needed resources. And so they developed, Congress working with the White House, the Franklin D. Roosevelt administration, created a policy, a legislation called the Homeowners Loan Corporation Act. That law was then implemented by state and local policymakers, working with property appraisers who were authorized to go into the neighborhoods of over 200 cities and to grade them from an A, B, C, or D, right? And align them with a color code. So the A communities were aligned with green, your B were blue, your C were yellow, and your D communities were red. A communities were your affluent white communities. B communities were your middle class white communities. C communities were your quote unquote undesirable immigrant communities. So these were largely Mexican, Cuban, Jewish, German, Irish, Italian communities at the time. And then lastly, the D communities were your predominantly African American communities, and they were classified as hazardous. Now, after these reports were done, they were compiled, then sent back to DC, which was then used to create additional policies that further starved these red line communities, primarily African American, and to some extent these yellow line communities, of the resources that they need to not only survive but thrive in our society. Interestingly enough, according to the DC Policy Center, there is no such map for DC. And they're not sure if DC was intentionally excluded or the map was not preserved. So that's a really interesting development. But in DC, you all were notorious for your racially restrictive deed covenants, right? And enforcement of these deed covenants by the courts in the District of Columbia, essentially intended to keep the city segregated for decades. So let's move on for the sake of time, right? We know then that there were additional policies after World War II. There were additional facially neutral policies, again, that were developed. But once they were implemented, they had a disproportionately negative impact on Black and Brown communities. So think about the Housing Act, right? That created the Urban Renewal Program that raised housing, apartments and houses, displacing over 500,000 African Americans in this country across the nation. Think about the Highway Act, right? When you think about our cities today, and you look at many of the Black and Brown communities in this country, you may have noticed a major highway splitting these neighborhoods in half, or the railroad tracks dividing these communities from other communities. You may have noticed bus depots being disproportionately located in these communities, or other infrastructure. So as we think about the infrastructure bill that President Biden has just signed into law, and as they implement this, it's really critical that we understand how these past infrastructure bills have actually, once they were implemented, have done great harm to Black and Brown communities. We must take an equity lens as we are implementing these policies. So interestingly enough, all of these policies throughout the years coming up to today have created essentially a poverty tax on communities of color in the form of higher payments for auto insurance, mortgage loans, lower property appraisals. We're reading about that all the time today, right? We've seen, these food, pharmacy, and hospital deserts in our communities, right? Making it more difficult to access resources to improve their health and maintain their health. And now we're also seeing another existential threat, climate change, or the climate crisis, impacting the world, creating climate gentrification in communities of color. And ironically, where we have been moving from redlining now to blue lining, because we see the sea levels rising, we see the temperatures getting hotter, right, and whatnot. And now it's creating the displacement of, again, thousands of racial and ethnic minorities across the country. Well, all told, we can see the impact that these political determinants of health have on communities of color. As Professor Michael Marmut out of UCL London has stated, life expectancy as a measure of health tells us a great deal about how we are doing as a society. But the inequalities in that society tell us even more. Where you live absolutely matters, right? And as you can see, the neighborhoods that were redlined, starved of the resources by acts of policy, are now today the very same communities that have the lowest life expectancies and the poorest health outcomes. Notice the significant difference in life expectancy in the District of Columbia. Well, we've talked about how policy has been a driving force for many of the health inequities we see and experience in our communities. But it can also be used to advance health equity and health justice in America, right? There is a roadmap that was created because only policy can fix what policy has created in the first place. So let me just quickly talk about the efforts by health equity champions, much like yourselves, right? I quote William Faulkner, where he says, "The past is never dead. It's not even past." And how true is that as we've been going through the last 2 years of this quadruple pandemic? Well, let me take us back quickly to 1789. That was the period in which the United States government was formally organized as a constitutional republic. And at the time, abolitionists working with mental health reformers, advocates for homeless individuals, and others came together and they started to strategize. And they said, you know what can we do to get this new government to provide for the general welfare of its people? Well, they decided to recruit a major policy influencer, Benjamin Franklin. And Benjamin Franklin, although he'd been a lifelong slave owner, as he got older, as he aged, he came to understand that that was a very oppressive system. It was an evil institution. And so he agreed to lend his name to the cause. And he signed the petition. In the petition, they argued for the federal government to stop the separation of children from their enslaved mothers, to stop the breakup of these enslaved families, to abolish slavery once and for all, to provide the necessities that these individuals needed, not only Blacks, but poor whites as well. They advocated to provide adequate housing, education, and true employment opportunities. Well, if you think we're having a very contentious debate during this fourth great awakening in our nation's history for health equity, it seems to me from the records that it was equally, if not more, contentious. And the House and the Senate basically started to have a huge debate. The Senate said, we're not even going to dignify Benjamin Franklin and these abolitionist requests. We're not going to dignify with an answer. But the House said, we can't let Benjamin and these folks get away with this. How dare they? Don't they realize that we're just getting settled? Now is not the time to be addressing these inequities in our society. Interestingly, though, after that report came out, or after their response was received, 3 weeks later by Benjamin Franklin and the abolitionists, Benjamin Franklin passed away. And that was the first time in U.S. history that the light of health equity had dimmed in federal policy in trying to move that needle of health equity. It would then take us 75 years later for the political stars to align, now through a major civil war under President Abraham Lincoln's administration. And as they were fighting for the soul of the country, Lincoln and his supporters believed that they would win the war, and they recognized that they would need to provide all sorts of services for the newly freed people, formerly enslaved Black people, as well as poor whites who were going to be displaced as a result of the Civil War. And so they crafted the Freedmen's Bureau Act, our nation's first major health reform law, really and truly the first federal policy to address the health inequities in our society at the time, and to really address the social determinants of health. Because in that bill, they included everything that advocates had argued for 75 years prior. They argued for the necessities, food and clothing, housing, education, security even, right? And healthcare. But healthcare was the one provision that was holding that bill from passing. And after 2 years, President Lincoln decided, in the spirit of compromise, to strike the provision from the bill and to sign it into law. Of course, as we know from history, after signing that bill into law, what happens? 4 weeks later, he's assassinated. But his supporters, not wanting to squander the crisis that it presented, the opportunity that it presented, they actually, upon rereading the law, believed that it did authorize them to go out and provide health care to newly freed people and poor whites. And so they went about establishing sanitariums and hospitals, clinics, and other healthcare entities. They started to recruit physicians and nurses and other health professionals into the South and around the country to provide healthcare services to now Black and poor whites. But as we have seen over the last 2 years, racism does not sleep in this country, and hate never takes a break. And that's exactly what we saw from 1865 to 1872, when opponents of health equity were unrelenting in their advocacy to undermine America's first major health equity focused policy. Succeed they did, and we know that it would take us 150 years later before the stars would align again, right? Where we would have another opportunity to realize a comprehensive and reticulated health equity focused health reform law under the Obama administration, what we call the Affordable Care Act. So in the last few minutes that I have, let me talk about how we can leverage the political determinants of health, right? Today, how can we leverage it to really advance health equity and to ensure that every single person in our community has a fair chance, they stand a fair chance to reach their optimal health and their full potential. So here's my definition of the political determinants of health. I define it as involving the systematic process of structuring relationships, distributing resources, and administering power. And they operate simultaneously in ways that mutually reinforce or influence one another to shape opportunities that either advance health equity or exacerbate health inequities. So let me break this down a little bit, right? We talked about, as we break down this tripartite definition, we talked about structuring relationships, distributing resources, and administering power. How does that look? Well, earlier you heard me talk about redlining in America through the Homeowners Loan Corporation Act, right? But there are a host of other laws that were designed to structure relationships in this country and still do today. The anti-miscegenation laws, right? At the state level and local levels. The blood quantum requirement laws that were designed to keep Native Americans from mixing with the general population. The anti-miscegenation laws designed to keep white folks from mixing with Black and Asian Americans and others. We know that our immigration laws are steeped in racist ideology. How about for those of you who work with people with disabilities, the fact that laws were created to explicitly prevent children with disabilities from receiving an education in schools. And even today, we see laws on the books making it very difficult for people with disabilities to access housing, right? The list goes on. When we think about distribution of resources, think about the dearth of programs and funding, right, for health services, special education, home and community-based services, social services, COVID testing kits, even vaccinations, and the list goes on. Not again an accident. And then perhaps the most contentious of this three-pronged definition is the administration of power that is concentrated within certain communities through redistricting, gerrymandering, restricting ballot access, voter suppression tactics, the voter identification laws that we are dealing with, or purging voter rolls of irregular voters, minimizing opportunities for early voting, closing or moving polling places, or penalizing groups involved in voter registration drives. We know that there are almost 24 states now that today are implementing or have created policies that will make it more difficult to vote. Why is that important? Because voting is arguably the most critical element of the political determinants of health. Voting can mean the difference between life and death, not only for yourself, but for your families, for your community members, for generations to come, because it does set up the policymakers who will in turn develop the policies that will either include your population group or exclude your population group. It is absolutely critical to think about it. Now, let's also, in the last minute that I have, let's talk about this, how this whole process works, right? And this is my wonky framework on the political determinants based on the evidence from a political science, legal, public health, and historical lens. And the idea here is that once a perceived health inequity is identified, you must conduct your due diligence to ascertain whether the health outcome is systemic, avoidable, and unjust. How far can you venture to understand whether it is an institutional or structural barrier that created is perpetuating or even exacerbating that inequity? What is the policy change desired? And can you demonstrate the value of investing in change? Because in our country, Advocates must understand the disquieting and harsh truth that the political determinants of health inequities have rarely been addressed, right? Unless their reduction or elimination served other purposes. What do I mean by that? Well, the success of any advocacy effort has depended on how palatable they are to commercial interests and whether there is an investment value to the government. You see, in this country, for those mental health champions listening today, you may be quite familiar with the history that mental health reformers had long made the moral argument that there are so many people with mental illnesses, substance use disorders, that are dying prematurely. We know people with serious mental illness die 25 years earlier than the rest of the population. Mental health reformers have been making that moral argument that the government needed to do more for these people, but they were ignored. They argued till their tongues bled, and they were still ignored. It wasn't until 150 years from the founding of the country that mental health reformers, having now gone through three major wars, the Civil War, World War I, and World War II, when the country was at its wit's end, suffering a mental health crisis, recognized that they needed to make an economic and national security argument. Now they had the attention of our policymakers. And now, after World War II, right after it, they recognized with the admirals and the generals that 20% of young people, when they did a study, had a mental illness that prevented them from entering into military service. 40% of young people were leaving the military in droves because of PTSD and other ailments. And 60% of our hospital beds were being occupied by young people, again, with mental illness. Now the government could no longer ignore it. Now mental health reformers understood that if they tied their arguments, showing the economic argument and the national security argument, they could make some headway. And surely enough, they finally got America's first mental health reform law passed. They created the National Institute on Mental Health. So where do we go from here? We've looked at how the foundation of our systems fuel inequities, right? How the political determinants of health inequities continue to ravage our communities through our marginalized and underserved communities, no less, and how they lend racism a helping hand. So where do we go from here? Well, I'll tell you where we can't go, and that's we can't return to normalcy, right? Normalcy failed us before and will fail us again. Normalcy before COVID-19 left marginalized communities without the resources they needed to survive and without the data to tell their stories. We absolutely cannot ignore the tough lessons that we have learned by attempting to return to a pre-COVID-19 mindset. You see, the inequitable landscape before COVID-19 was just as dire as it is today, which means we have an opportunity to act right now. Normalcy is not equity and justice. Equity and justice should be our only options moving forward. So let me close with these 5 things that we can do to elevate health equity and justice in our community. Again, I want to thank DC Health for allowing this conversation, because we do have to engage in the tough conversations around race, place, and class, and advocate for a full commitment to tackling health inequities upstream in all areas, much further than we've been willing or able to in the past. We have to work upstream to address the social and political determinants of health inequities, understanding when they are at play. It matters. We also need to recognize, as a transient society, it's so easy, right, to make judgments about the people living in our communities. But we need to do a better job researching the history of the communities and address the past policies and programs, right, as well as current policies and programs at all levels that have been creating, perpetuating, exacerbating these inequities. Remembering, as we just discussed, that in policy, exclusion has always been easier to realize in policy than inclusion. We also need to do a much better job with our engagement with communities, recognizing that the people who are closest to the pain, closest to the problem of these health inequities, are the ones that should be leading the solutions, right? So we've got to strengthen our networks and our engagement. And then lastly, we need to understand that health equity begins and it ends with the political determinants of health. The good news today, I hope you never forget this, is that these structural barriers and the resulting inequities are not permanent. That's wonderful, right? But it will take individuals like yourselves committed to stomping out these inequities, right? To create that greater action and collective agreement to move that needle. Unless we do these things, I'm afraid that we will make little progress in keeping the social determinants of health in check. So, in closing out, I want to leave you with this final thought by my dear friend and mentor, Dr. David Satcher, who was our 16th U.S. Surgeon General and the founder of our Satcher Health Leadership Institute at Morehouse School of Medicine. Because health inequities and health injustices will persist like they have for generations in America unless we seriously tackle the root causes or upstream factors, notably the political determinants of health. And what Dr. Satcher reminds us is that we need more so than ever before leaders in our communities who first care enough, know enough, have the courage to do enough, and who will persevere until the job is done. First, you got to care about our communities, right? But caring is simply not enough, as we've discussed. You've got to know enough. You have to educate yourself on these political drivers of inequities. And as you have also heard, this movement to advance health equity is not for the faint of heart. It takes tremendous courage, but it also takes tremendous patience and perseverance to get the job done. I want to thank you all again so very much for the privilege of your time and again for your courageous and humbling work to elevate the health of every single person in your community. Thank you so much.
All right. Well, I will just thank Daniel. I really wanted to point out that and underscore when the roots are strong, the fruit is sweet. I think it's the perfect kind of thought process that we need to work on the root causes of health inequities, and that together we can move this work forward and to really make the difference that we need to have. I had a few questions that I wanted to pose to Daniel because I knew we had a few minutes left. And in particular, I wanted to ask about how do we move beyond models that simply compensate or ameliorate the inequities that we have. That's the way we've been approaching this thus far. But we really need to move to a point where we're doing more than that. And Daniel talked about the fact that we can't just go back to the pre-pandemic system that we were in. We need to redouble our efforts and triple our efforts to make a whole lot more change going forward. I hope you all appreciated how Daniel has really, what I call, engaged our GPS, pointed us in the direction that we know we have to take the road, less traveled thus far, with a lot of hard work, with a lot of passion. And thank you all for your participation.